My name is Dr. Belinda Chan. I graduated from medical school 16 years ago in Los Angeles, California. I've specialized in neonatology in the past 13 years. Currently, I'm the assistant professor in the neonatology division and the adjunct faculty at the radiology department at the University of Utah, which is located in the Salt Lake City, Utah, America. Now, I'm going to walk you through the POCUS use and challenges that I face in the NICU. To paint a better picture for you, let me share a typical scenario. After a premature baby is born, our whole team will surround the bedside and try and simulate the baby to breathe and cry. Crying helps the baby to clear the lung fluid. So when my kids cry, my mommy loves crying. What can I say? After a while, the baby is still blue and breathing hard. We get a chest x-ray, which show non-specific haziness. Lung ultrasound may help to differentiate different diagnoses. Is it transient tachypnea of newborn, which is a transient retention of lung fluid, meconium aspiration syndrome, or other things that you guys may be more familiar with, pleural effusion, pneumonia, pneumothorax, chest mass. And one more possible disease that only found in neonate is called respiratory distress syndrome, RDS, which is premature baby that doesn't produce enough of a substance called surfactant, which help the lung to expand. We have to make a fast and precise decision to intubate the baby and give surfactant. It is never benign nor easy thing to intubate a baby with tiny mouth. And I would like to show you some images of babies with RDS before surfactant was given. Usually the lung images have confirmed B lines and almost complete whiteout. 6 hours later, after the surfactant was given, the B line are disappearing along lung ultrasound, and it correlates with baby's clinical improvement. And usually after I stabilize the baby, I'll put umbilical line through the baby's umbilical cord vessel. The lines uses as an IV for fluid, lab draw, or even blood pressure monitoring. Ultrasound is better at verifying the lung position than X-ray. These are the images of umbilical venous catheter coursing through the ductus venosum in the right atrium, and all these the image of umbilical artery catheter in the descending aorta. And here's the X-ray that shows that umbilical venous catheter seems to be heading the right position on X-ray, but the ultrasound confirmed that the line is in the liver and is the wrong position. Another scenario, which is my worst nightmare, is a baby born to a mother with no prenatal care. Surprise! It is never a good surprise. The baby's slow heart rate and no breathing effort. The baby is not responding to intubation or chest compression. So I put the ultrasound probe for a quick POCUS scan. I check the heart function and see if the heart is totally abnormal. It could be a dilated heart with poor function, and hopefully it's not a heart that is thickened and collapsed. POCUS can also help to rule out pneumothorax, pleural effusion, or pericardial effusion. If ultrasound found fluid pocket that impede blood circulation and lung expansion, then ultrasound can guide tapping into the fluid pocket in the heart, lung, and abdomen. At the same time, baby also have a little soft spot on the top of the head due to non-calcified scalp. We can look into the brain to see if there's any major head bleed, until the radiologist can get and scan the baby's brain. Another common use of POCUS is a baby have no urine output after surgery. Is it urine retention from morphine or dehydration from surgery? Do I put a Foley in? It is not easy to put a Foley in a tiny baby. Unfortunately, it has happened that Foley was inserted into the wrong hole of a 1-pound female baby. Do I give fluid bolus? But for neonate, unnecessary fluid bolus can overload the tiny heart. Bladder scan is easy to do and is very helpful. It takes the guessing work out of making clinical decision. Besides ultrasound guided procedure I mentioned earlier, POCUS can also help with lumbar puncture or spinal tap. Sometimes after an unsuccessful channel tap, there will be a hematoma that's being created in the spinal space. An ultrasound can help us to identify that and not put a needle in it anytime soon. And then after a few days, the repeat ultrasound may show that the hematoma resolved. Now there's a nice space with CSF for me to tap. NICU is a very unique space. The other thing different about my patient is there's a saying called, children are not small adults. NICU babies are not small children. There are many differences between a neonatal ICU and NICU or other critical care unit. I can think of 3 P's: patient, parking, and parent. Let me explain that in detail. The first P, patient. Size doesn't matter. My NICU baby is tiny. The smallest baby that I've ever taken care of is 245 grams. It weighed like a glass of water that fit right onto my palm. We also take care of bigger baby that weigh up to 4.5 kilos or 10 pounds. My arms get tired after changing the diaper. The L4 and 12T ultrasound probe can occupy almost half of the baby's chest. Commonly seen NICU problems are prematurity, breathing difficulty, birth trauma, infection, blood diseases, congenital heart diseases, and other serious birth defects. The baby also have very immature skin. Little ultrasound gel can make them get cold very quickly. And the baby move around like a wiggly worm. They won't hold still during ultrasound scan, nor would they keep their hands away from your probe. The second P, parking. NICU has compact parking space. NICU babies have many life-sustaining equipment. With this tight workspace, small equipment is often preferred, so Go fit nicely at the bedside. The third P, parents. I attend to the parents' emotional distress. Parents love seeing the baby's heart beating on the Go screen when I'm scanning. They appreciate that I integrate innovative and non-invasive technology into their baby's care. I love the lung diagram. It saved me time from labeling each lung field. Imagine, it is hard to scan a wiggling baby and labeling at the same time. It also reminds me to obtain all the images in each lung field for a complete exam. After the image is stored, the follow-up tool along with lung diagram helps me to follow the disease progression over time. I feel that ultrasound have reduced my need for X-ray. Remember earlier, I talked about that we sometimes put umbilical lines in the baby's belly button. We constantly worry that if the line migrate low into the liver or deep into the heart, both are not ideal position and can cause complication. We have to do frequent X-ray to confirm the line position. Ultrasound eliminate the need for those frequent X-rays. I would like to share with you my 3 favorite probes. First one is L10 to 22. It is lightweight, so the weight of the probe itself doesn't compress on the blood vessel when I gently lean it on the skin during line placement. The small footprint allowed me to maintain good contact with the tiny arm. The high frequency allowed me to see the tiny superficial vessel on the neonate for line placement. The second one is the 8C, which is the workhorse. I use it for everything. It is easy to maneuver around the tight body shape, and it can penetrate through the ribs very well for very good image. The 12S give me a very good cardiac image for heart that beat 100 to 200 times per minute, and it penetrates the ribs very well. Sometimes I have to use one hand to scan and the other hand to hold the pacifier to calm the baby, so less button and more presets on the venugos are pretty awesome. My favorite thing is labeling the lung and EFAS diagram. I can focus on scanning versus labeling, and also remind me to obtain all the images for the specific scanning protocol. Machine have a super fast start time during emergency use. I don't have to wait for the machine to turn on while I am actively doing chest compression on a baby. Ultrasound is no longer a guessing game of some fuzzy POCUS image that resemble abstract paintings. It is less likelihood for misdiagnosis. It takes the guessing work out of decision making. Most importantly, that Fenugo is best for the NICU is because it has such a small enough footprint and high enough frequency probe that are perfect for the NICU baby. In summary, Fenugo is portable, is user-friendly with touchscreen and smart tools, and it has really good image quality with NICU appropriate probes.